Good afternoon, everyone. Bonjour. Merci d'avoir venu. My name is Eric Chemet. I'm an associate professor at the university, holding various different hats, and I'm really happy to be here today to talk to you about our Healthy Seniors pilot program called Technology-Enabled Proactive Community-Based Health Assessments. Just quickly to give you a little bit of context about who I am. So I'm a researcher, a former New Brunswick Innovation Research Chair in Medical Technologies. So I've been fairly broad working with industry partners and clinical collaborators over the last 8 years, I guess. My research does tend to work in machine learning, AI, and data science, typically for the design, translation, and impact of technology on human health, movement, and happiness. And that can take various different forms, including diagnostics, digital health, certainly aging in place, rehabilitation, and recently some biometrics work as well. So fairly broad field, but all centered around our use of data and our ability to understand what that data means.
Recording it.
So I will jump into this. I think probably most of us know this, but New Brunswickers are not the most healthiest individuals across the country. The numbers range between 62 and 77% reporting, depending on where you look for them, have at least one chronic condition. And the rate of multiple chronic diseases is increasing rapidly, with New Brunswick Health Council having reported pretty drastic increases for a population the size of New Brunswick's over a short period of time. So we know there's a challenge with managing chronic disease and that it's a different healthcare problem than we may have traditionally faced before. In addition to this, we have a population that is feeling scared and somewhat alone. The wording I use here is drowning in an epidemic of chronic disease. It's been reported by the World Health Organization as an epidemic, but fear and loneliness are also rivaling those pretty heavily, of course, expedited and worsened by the COVID pandemic. What's worse, we have an informal caregiver sector in Canada that's providing billions and billions of dollars of unpaid care to help keep our seniors home and healthy and happy, but they're also getting ready to break. They're feeling the stress of being asked to do more and more without necessarily the right supports in place. And what's challenging from a healthcare system is we don't have much of an ability to plan for changes in states. So whether that is going from living in home to a long-term care facility or to a hospital. And so the question I asked was, how can we provide care to individuals living in the community, but more importantly, how can we show that we care? And then how can we enable more effective community supports for aging in place? So as an engineer, I took the approach of, well, let's see what's going on here. And we started to have a look at the healthcare system as it exists. And the healthcare system, for everything that it does well, is not as well suited for this change in use of the system in terms of chronic need, but we typically have an acute response. And if we think about this from a vehicle perspective, you can think of, it's one thing to take your vehicle into the shop once you've had an accident, but we'll also often do a lot of preventative maintenance as well with multiple sensors in the vehicle trying to keep track of things. So the healthcare system is a little bit overwhelmed and reactive because we don't really have a great ability to plan for those visits in the same way. And what it's doing is leaving patients with not the best access to the care that they're looking for and the experiences and what they're looking for now, especially as we move into this new age of access to information at their fingertips the rest of the time. We're finding that they can be fairly frustrated with not really having access to their own health information. Of course, this is leading to things like increasing costs. And again, from the system perspective, it's difficult to plan for that. So we started looking at it and saying, well, what are some of the challenges? And we know that there are subjective assessments a lot of the time that may lack some context. So, the evolution of diseases and how they apply to a particular person can't be completely seen in just one checkup. And so this is leading us to this sort of pound of cure. If we look at the old expression, an ounce of prevention, a pound of cure, obviously we'd love to prevent, but it's difficult to do this within the existing system, within the framework that we have. So certainly technology has evolved as one potential solution, and it's becoming more commonplace. However, when we poll seniors and their caregivers, we get various different answers to that. And why have you not used a technology, or why might you not want to do that as a way of instrumenting your home or using your own technology to help monitor yourself? And if I boil them down to three main concerns, I tend to call them concern, cost, and complexity. So concern is a human psychology thing. Until something gets bad, we don't tend to invest a lot of energy into it individually. Cost is, of course, a concern for many New Brunswickers. The ability to actually purchase these technologies and have the infrastructure necessary to use them effectively can be an impediment. And complexity as well. So not every New Brunswicker is in a situation where we can actually use these technologies to full benefit. In talking to informal caregivers who are taking care of family members, they say it's just one more thing. It's one more thing I'm being asked to do, and I'm not really sure exactly what I'm supposed to do. So the question is technology actually relieving a burden, or is it potentially actually creating more of a burden when we're talking about trying to support people aging in the community? So together with a number of other colleagues, we set out to create a platform, and to understand if we could create something that would help support this aging in place in the community, but address some of these different issues along the way related to the individuals being cared for, the people caring for them, and the ability of the system to actually maybe be able to plan for these changes in state a little bit better. And so we sought to use regular health monitoring to promote human connections rather than just using technology to perhaps isolate people more, and to enable these proactive planning and interventions. So I brought in some of my very talented colleagues from various different locations. So Dr. Reed, Dr. Jarrett, Dr. Chopra was a postdoctoral fellow with me, Dr. McIsaac, Stakanova, Bateman, and Ray, so from various different organizations. And we partnered with Verisource Solutions, a local provider of digital health solutions. We were fortunate to receive funding support from the New Brunswick Innovation Foundation, MyTax, and the Lockheed Martin Research Fund at UNB to support the development of this platform that I'll walk you through quickly here. So jumping right into it, this is what I call the pitch model. You can think of having the patient at the center of this. Of course, all care should start that way. But for the purpose of this model, we've got this sort of data repository, again, referring back to the fact that I'm an expert in machine learning and data analytics. But if I can just walk you through the model quickly, maybe it'll give you a sense of what we're proposing to do here. So we might have some administrator who could enroll the clients that we're looking to take care of into this pitch monitoring program, selecting from a set of modular toolkits that I'll walk you through in just a moment. Based on that enrollment, we would have outreach personnel going into the home on a regular basis. And there's a couple of reasons we want to do this. One, again, is to create that sense of engagement, keeping people aware of their own health as they're going, but also creating those connections, those social connections, to reduce some of the burden. So these outreach personnel are using toolkits to do the assessments so that the individuals that are caring for those people in the home can sort of not worry about that quite so much. It also gives us a checkpoint in the home to make sure that everything's going okay. Based on that, the data are pulled up into the data analytics engine, where we can actually look at additional context and trends. So there we can use machine learning and data science to understand not just, is this one particular measurement higher or lower than it should be, but how are things changing over time? Are there trends that we could use to try to predict potential future changes in state so that we could plan for them better? Based off those data, a medical professional can provide oversight, so they can view the data themselves if they'd like to, or they can rely on data-driven alerts that bring things to their notice. And they can escalate that as necessary through the regular healthcare system or through the circle of care that's supporting that individual. One of the important aspects that we want to do here is we want to take the data that are created and use that to its maximum benefit. And so one of the things that we want to do is we want to be able to mobilize and support the circle of care to intervene if necessary, and to be able to connect with that individual as well, trying to reduce that gap that we often see between seniors and the community. And so this is the ability to take this data, make it actionable, but not necessarily immediately put additional burden on the healthcare system by leveraging that circle of care that just may not have been informed before. If this is being delivered through a long-term care facility, these data could also be shared back with a facilitator or a provider, or if it's outreach personnel through a personal support workers program, these data could provide higher level information about their clients, about planning for their clients, and potentially about process improvement as well. And then finally, we want to be able to make the population level information here available to the health system at large for, again, so population level data analysis planning of resources as well. So this, at a nutshell, is the pitch model. And I mentioned quickly these modular toolkits. The idea is we're not looking specifically to only care for one particular disease. We understand that individuals are complex and there are many different things that could be affecting their health, not just individual chronic diseases, but many different factors. So the pitch platform has been designed to be modular, to accept many different toolkits, whether that's physical devices integrating into the platform where we can capture those data, or whether it's the use of assessments to do questionnaires, or even just ask questions about medication adherence, about outings, the number of visitors individuals have had. So again, the idea here, this is a platform that's flexible, that enables us to scale and test many different things at the same time. So these are just examples of toolkits that could be used through the platform. Through this, even though the back end is fairly complex and enables the secure analysis of these data, the whole goal is to make this accessible to members of the community who may not necessarily have a lot of health or digital literacy. And so the pitch assessments interface is a simple to use mobile interface that works on your cell phone or on a tablet for collecting routine health assessments. The idea is that we can streamline and use a workflow to guide a user through a series of questions or steps, and to walk them through with very little training, but be able to actually do these assessments in a repeatable and trustable way so that the data are usable within the system. We've partnered with Verisource to build this entire framework over top of the Verisource framework, which has been used by government already for various different applications, and we'll come back to again in a little bit. Based on the data that are collected through these assessments, we are continuing to develop the pitch analytics engine, which automates the analysis of either acute instantaneous data or longitudinal data, looking for things like anomalies in those data, looking for trends that are either positive or negative, and eventually we'll be building into machine learning to do predictions for things like falls, hospitalizations, change of states, and things like that. So the framework that we're using allows us to actually implement these. Of course, at the university, we're doing the research in the machine learning and AI aspects, and we'll be building them into this platform as we continue to build it out. The other important part of this we saw in that cloud bubble was the ability to share the data, not only with the end users themselves if they'd like to see it, but also with those who care for them. And so the idea here is these apps will share and present the information in an easy to understand way, so that members of the community can be using those to trigger customized alerts, to tune settings. So for example, we can go in and set a particular threshold on any one of the parameters that gets measured. So if I want to understand, I want to make sure that my mother is healthy, I'd like to know if her blood pressure goes above a particular level or her weight drops below a particular level. I can customize that data, which she shared with me, and receive alerts that let me know when that has happened so I can intervene. And the idea there is to engage and connect that circle of care as part of the health and wellness of that individual as well. So the Healthy Seniors pilot program came along, and we were at a point in time where we had built the platform and the ability to do these assessments, but we really needed to understand whether this was something feasible within the community, and particularly to be used by individuals that may not have had a lot of background training in this area. So the Healthy Seniors pilot program, we were successful. We partnered with Kindred Home Care, a large home care provider here in the province, to deploy these tests on a regular basis via their personal support workers and via their established network of clients that they had across the province. So we were fortunate to receive this funding. It would have been very difficult to do otherwise, for sure. And we wanted to understand how to validate the feasibility of using these pitch assessments. We called it Wellness Check for the purposes of this program, and to conduct these regular health assessments in the community. Specifically, we wanted to train caregivers to use the platform and conduct health and wellness assessments. So we wanted to evaluate our ability to do that and their ability to continue to do that. To complete sort of a needs assessment of what these particular end users might require and do user acceptance testing of the platform. And then to understand factors that may predict changes in seniors' ability to stay at home, and to perform a retrospective analysis of assessments to identify whether state changes could have been predicted. So this is the goal of this project. The goal wasn't necessarily to intervene right off the bat, but to collect the data at this point to understand whether we could have intervened or we could in future installments. So through this Healthy Seniors pilot program, we integrated with the Kindred Salesforce platform. So Kindred has a very nice platform for managing their clients and managing appointments. So we worked with them to integrate the two pieces of software together for the purpose of the project. We were able to train almost 200 of their personal support workers all across the province. This was done with a less than 1 day training session that Kindred put together. It basically walked them through how to use the app, and then more importantly, or as importantly, how to actually do the assessments. So they used the Pitch platform. It was installed on all of their own devices. And then they used things like blood pressure. We measured weight. They did a 4-meter walk test repeated 3 times. We did an SF36, which is a questionnaire which asks questions about quality of life, mental health, physical well-being. And a mini cog assessment, which assesses mental health and mental acuity. Through Kindred's normal methods, we also collected notables, such as whether the patient had fallen, whether they were hospitalized, whether they went to a long-term care facility, and whether they passed away. So we were able to assess over 100 users weekly over an 8-month period. It had originally planned to be a little bit longer and larger than that, but COVID reared its ugly head. So Kindred really rallied around with us, and we were able to successfully do the 100 users over an 8-month period. And so I'd like to sort of say thank you to Kindred for the work on that as well, to make sure that this continued to go forward as a research project despite the pandemic that's been ongoing. So as we started to do this, we were already getting feedback from clients immediately. As soon as we started to deploy the platform, we were getting noted improvements in communication with the clients, the senior management, and the personal support workers. And we noted a lot of additional motivation, particularly on the part of the personal support workers. And we were getting anecdotal benefits by all of the different members, including members of the circle of care. So these, again, were early on in the process. A couple of quotes here. One of the best feelings was being thanked by his nurses and doctors, as they believed the Wellness Check initiative to be a great motivator in the client's situation. I'm looking forward to recruiting more clients for the project in the future. So we saw, even though as part of this deployment of Pitch, we did not use the data sharing aspects, it wasn't ready to go when we launched this project, we did see that the information was already being shared and being used as part of the care for the client. On the part of the clients, we saw a lot of information about reduced fear, particularly in the face of COVID. So when you don't know, you worry. Being able to check is comforting, said one client. And then again, it's comforting to check in regularly and see you're on an even basis. So this is some of the qualitative information that was coming back as we were starting to deploy this and sort of excited about the way that was going. The formal period of data collection finished just before Christmas this past year. And so we've started to do 2 things. We've started to do a qualitative analysis where we conducted interviews with clients, caregivers, and management. We've done some of these through focus groups, some of those through individual phone calls and Teams meetings. And my team's been looking at transcribing all those and doing thematic analysis of those recordings. And we are seeing some pretty significant themes emerge as part of that. I'm just trying to bring up the file here, sorry. So improved access to medical assessments is one that has come up. So a lot of these clients feel that they don't often get touch points with the healthcare system, and really felt that there was some benefit to having this regular oversight of the information that they have. One of the management team said this is right in the middle of this wonderful little pandemic we're experiencing. Our clients were restricted with visitors and medical appointments. And so this was a really nice safety net for them through that process. A second theme that is emerging is a motivator for further action. So the conversations that the clients would have with their personal support workers through the program has really been kind of eye-opening. So at first, some of those discussions could be a little bit difficult, but once they started to get through them, they really found that the awareness of their mental health and their physical health really motivated them to do more. So we see a lot of people coming and saying, look, I lost actual weight during the program. Doing the walking test every week motivated me to want to do better the next week. So they took the opportunity to follow up with some of these things, and patients also followed up with their families as well, who rallied around them to try to improve as well. So again, we see this element of, if you measure it, you can actually then try to influence that as well. We do see the theme of mental health and discussion of mental health coming up very, very prominently, particularly as it relates to COVID. Some of the questions in the SF36 relate to, again, mental health and quality of life. And some of the clients found that difficult at first, but then having those conversations with the personal support workers created great value for both those clients and the support workers, because it bonded them together, allowed them to have those difficult conversations at first, but then created a really strong bond. And we found from the personal support workers, they felt a greater sense of satisfaction that they were actually helping to make a difference in their clients' lives. This reassurance reduced anxiety. I had a couple quotes there earlier that spoke to that as well. But we do see a lot of this element of the reduced risk of the fear of the reduced fear of the unknown. We had one quote that said, "I had a pulmonary embolism in the spring and I live alone. Before I got into this program, I didn't have any special contacts except for my family. The extra care every week just helps to relieve my mind." And so we know that individuals living alone in the community are receiving this benefit by these regular interactions. Even though the personal support workers had already been going into their home before, the increased motivation and focus associated with these assessments seems to be a positive output at this point. And then finally, this improved caregiver satisfaction, the sense of purpose. And so this was a very strong theme coming back from the very beginning and through our thematic analysis. And a quote here is, "It validated that they were people with skills that could move forward changes in their environment and their world. I think it validates that they aren't just people who go in and do house cleaning and laundry." And so we've had conversations with the community college about these types of programs. And we do know that the kinds of things we're asking them to do, they're actually trained to do when they're in college. So we're seeing this potentially as an opportunity to elevate these personal support workers to their full scope of practice, and a way of offloading some of the initial or some of that work off of the healthcare system. So a couple of things here. There's some data plots that I'm just sharing for the purpose to see that the data analytics that we're doing. So the quantitative analysis is ongoing, because we're just getting the data in the last month or two. So we're starting to go through this. We're looking at a couple different things. So versus the control group. So we had the 100 clients that received the assessments on a regular basis, and we're going to compare them to a control group of Kindred clients who were not part of the study. We're in the process of doing that. We're of course looking at pre and post things. We're looking for outliers and trends in the data that could be predictive of these kind of notable kind of things. So if we look at one particular example, when I bring this up, this is one individual. The orange bar here notes a fall occurred, and the red bar notes a hospitalization. So these are some of the results of the SF36, where a higher value is better. We see an overall trend downwards leaning up into this particular fall, followed by a fairly low plateau afterwards. If we couple that with blood pressure measurements that were happening, they're not indicative of the drop before the fall, but we do actually see a drop in both blood pressures after the fall leading up to the hospitalization. So these are the kinds of things that we're looking for in the data. One individual measurement there is not going to tell you a whole lot, but the trends in the information can be quite compelling. A couple other examples here. This was from the 4-meter walk test. We had clients do 3 different trials of 4 meters. The reason we did 4 and not 6 is because we arrived at that length for most of their homes. It seemed like an easier distance to measure and do. So they did those walks, and we see for one client here was hospitalized shortly after the second measurement. But if we compare that to earlier assessments, we saw that their speed had decreased drastically right before that hospitalization. Again, potentially indicative of something that could have been intervened on. And on the right here, we have another example of a general health survey. This comes from the SF36, where a perfectly healthy person would have a shape that would be as large as possible. And we see an earlier assessment where they didn't feel like they were particularly limited in their physical role. But right before their hospitalization, we see that that dropped all the way down. And so we see a general decrease in the area of the shape as well. A couple quick things to note from a population level. So again, there's interest in planning for a particular individual, but I wanted to show a little bit about at a population level, the power of something like this program. So this happened to coincide with COVID, of course. It wasn't the intention of the study, but a couple trends that we've pulled out of this. This is the population level response to perceived role limitations due to emotional state. So this is effectively how people are feeling their emotional state is impacting their day-to-day basis. And each of these individual points represents averages across the users for a given point in time. Higher is better. We would like patients to be as high on this as possible. And what we saw is we saw a very steady decrease through the initial portion of the pandemic when there was a lot of fear associated with what was happening. So a fairly drastic and clear change. When we changed the green phase, and yes, we've gone through some other phase since then as well, but certainly there's been a bit of a different public mentality to the pandemic. We see that it's much flatter and actually increasing a little bit. So we're certainly not back to where we started, but we are seeing at a population level within this group that there was a very strong initial effect of the pandemic and then a change as things started to open back up, and maybe things are slowly creeping back up in that emotional state as well. Similarly, we see the same thing in terms of physical limitations. So this looks maybe not as drastic because the scale is different. However, we see the same thing where people were reporting that they felt the limitations of their physical state associated with the isolation with COVID. We see a steady decrease across that same first period, followed again by an increase, and maybe we're getting a little closer to back to normal than we were on the emotional state. So an interesting side thing to look at with these data is at that population level, even with just these 100 clients, we can start to see some of those trends. And so I like to imagine what we would see if the numbers were much, much larger. So what's next? So these Healthy Seniors pilot programs are designed to pilot these things and to understand what's possible, what could be adopted that comes out of these things. We're continuing to do the analyses. We'll be filing our report later in the spring, which will include the full qualitative and quantitative results of the data and compared back to the control groups. We do have an application into round 3 of the Healthy Seniors pilot program, looking to try to scale this in size and function across 3 levels of care. So the nursing home, the assisted living, and the community. We'll wait to see if that is successful or not. And importantly, what we'd like to do now, we have the data sharing capabilities built into the pitch platform now. So that it's operational, and we have that ability to also take the assessments that are done by the personal support workers or whoever is deploying those and share them with the circle of care that's surrounding that individual. So we'd like to also be able to test that functionality. Of course, in partnership with VeriSource, we're interested to explore opportunities for commercialization and continue to scale, which I think is the motivation of these Healthy Seniors pilot program, is understand how we can take these things and provide benefit to the community and to continue to build on some of these other aspects of the program. So one potential way to do that, just before I finish up here, is a model that I thought I might bring to our attention as New Brunswickers, I guess. And this is very similar to the model that I showed in the cloud diagram, but it's also leveraging some of the things that we already have in place. So VeriSource, of course, is our industry partner. We built this over the VSF framework, of which Department of Health is already a subscriber. So we're not looking to do anything here from scratch. Because we've partnered with VeriSource, we actually have the ability to pull the data that we bring into Pitch through these wellness checks into a repository and actually tie that back to the Department of Health and or the social development. And so what we're interested in doing potentially through a partnership would be to actually have the Department of Health subscribe to the Pitch platform, offer it free of charge to students who are training in the community college, and provide it to whether it's personal support workers, long-term care facilities, or in-home care workers to be able to deploy that across the province with their clients and with their families. And I think this could potentially have mutual benefits for all the different stakeholders. Of course, the families could get peace of mind with the data that's being shared with them. Potentially long-term care facilities or personal support workers could pass on the cost of assessments to end users if they feel that's appropriate. But of course, that data could be used to help them to administer their care for their patients and look for process improvement. Each individual facility through this data locker would only have access to their own data, making sure everything is secure and private. But then the Department of Health could actually have access to the high-level information for the purposes of planning as well. And so we could continue to work on the statistical analyses, the data products that come from that, and the machine learning. So this would certainly be one way where we could take this platform, scale it up across the province or through a part of the province in partnership to see if we can actually get the maximum benefit from this across as we go. So finally, that's about my time, I believe. So thank you very much for your attention today. Thank you very much for everyone involved in the HSPP program. I know that it is quite a beast to manage everything. And so we appreciate all your efforts there as well. I am a fairly collaborative person, and we're very interested in opportunities to work with other groups. So please feel free to reach out at any time. And that is my time. Thank you very much.